my screen now and my slides. All right. So thanks, Dr. Gayatri, for the kind introduction, and thank you, Dr. Aslani, for such wonderful talk. And that has laid strong foundation and basic in terms of valvular heart disease in pregnancy to our audiences. And this makes my talk a lot easier. Let's dive straight into valvular heart disease in pregnancy, the role of an MFM specialist. Let me walk you through my agenda. We'll first talk about the role of an MFM specialist in the management of this condition, and then our proposed referral pathway for patients with valvular heart disease in pregnancy. What do we do in the MFM clinic? And the importance of MDT as per discussed by Dr. Aslani. Then we swiftly move forward to controversies in management of valvular heart disease, specifically on percutaneous intervention and anticoagulation for mechanical heart valves. And I would like to also touch on pre-pregnancy care, which is one of the most important stage in a woman in reproductive stage. And we summarize with some take-home messages. Now, the recent years, many international bodies, including the European Society of Cardiology, the American College of Cardiology, and the American Heart Association, all propose this cardio-obstetric model of care. And so this is the one, the cardio-obstetric model of care for patients with underlying heart disease. And certainly, Prof. Uri El-Kayam and all as well have proposed one for the cardio-obstetric valve team, mainly including the maternal-fetal medicine specialist, specialists in valvular heart disease, specialists with experience in advanced echocardiography, cardiac radiology, cardio-obstetric cardiology, the cardiac vascular surgeon, the obstetric anesthesiologist, the cardiac anesthesiologist, the neonatologist, the pharmacies, and the nursing team and the social worker team as well. So what is the role of the maternal-fetal medicine specialist here? To me, I feel the role of the maternal-fetal medicine here is to lead the team. He or she should take charge of the case and take ownership of the patient and sync up the care of plan recommended by each relevant discipline. In a nutshell, he or she is the conductor of an orchestra to ensure the orchestra runs a smooth show. So let's look at the recent Embrace report released for 2023. And not surprisingly, cardiac disease remain one of the top causes for maternal mortality. And the maternal mortality ratio in Malaysia from 2012 to 2022 has not changed much. If you exclude 2021 being the peak of COVID era, our MMR ranges between 20 to 26, and this has not reduced at all. And if we look at the report published in 2019, looking specifically into cause for the MMR, associated medical conditions remain one of the top, and we know that cardiac disease in pregnancy is the main cause. Knowing that we have so many specialists, Malaysia and all other countries international is minting so many specialists in different expertise, different field. Why are we still having such high maternal mortality, and why are we not able to reduce it? Could it be because of increased number of firstborn being born to older mother? That means our primary gravida now are at more advanced age, because of demographic reason, because of social factor, education or financial reasons? Or is it because of advancement in medical care leading to increased survival of children with congenital heart disease who have now grown to reproductive age? Perhaps we should also think about lack of ownership of these patients in the care plan, failure to recognize the need for MDT involvement and escalation of care, or failure to compose and deliver a holistic care plan to our patient. We know that the physiological changes in pregnancy include the hemodynamic changes and the increased cardiac output, increased cardiac burden to a pregnant lady, together with obstetric pathologies such as preeclampsia, PPH, infection, has significant impact on the cardiac outcome. And vice versa, a patient with cardiac disease would have challenges when it comes to delivery, such as cesarean section, or when she experiences massive PPH. Let's not forget that cardiac risk is merely a piece in the entire puzzle. We, as the MFM specialists, will also have to take care of the patient's fertility issue, the patient's risk of miscarriage, the risk of thrombosis, antenatal bleeding, fetal growth restriction, placental dysfunction, PPH, and so on. I believe most of the audiences here are very familiar with the physiological changes of hemodynamic system throughout pregnancy. We know that the plasma volume and cardiac output significantly increase in pregnancy, up to 40 to 50%, especially peaked at 32 weeks onwards. And cardiac outputs increase due to increase in stroke volume and in about 10 to 20% increase in heart rate, especially towards the third trimester. And this is accompanied with drastically reduced systemic vascular resistance and hence mean arterial pressure. And all this actually happens even within the first trimester itself and steadily and continue to increase throughout the entire pregnancy. These changes is important to serve to meet the increased metabolic demands of the mother and at the same time support the growth and the development of the fetus. Other physiological changes in pregnancy include hypercoagulable state, increased glomerular filtration rate, increased liver enzyme, hemodilution, and protein binding changes, which has significant effect on pharmacokinetic and pharmacodynamic of the medications being prescribed to patients. Intrapartum, we have uterine tocopherol activity. The patient may be in pain or anxious. Patient may experience postpartum hemorrhage or infection and uterine involution. All this has significant impact in terms of the hemodynamic stability of the patients antenatally, intrapartum, and postpartum. Hence, the care plan for a pregnant woman should not be similar to one who's not pregnant, and we should not deny a pregnant woman of her rights to receive appropriate investigations and management. All these changes have to be taken into consideration for a precise care plan for patients with valvular heart disease in pregnancy. When we are deciding on the management of valvular heart disease in pregnancy, it's important to balance up the maternal health condition to the risk of fetopathy or threatened fetal well-being. Obviously, maternal health condition has to be prioritized. We also have to weigh up the risk and the benefit of conservative management versus intervention. Bear in mind that many investigations, medications, and interventions is safe in pregnancy, as per discussed by Dr. Aslanif in his discussion, in his talk. Let me walk you through a very typical clinical vignette in our setting. We have a 25-year-old Haranol at 12 weeks gestation, known case of chronic rheumatic heart disease with mitral regurgitation. Her last echo was 5 years ago. She was lost to follow up, and that echo showed mild to moderate mitral regurgitation. She's clinically asymptomatic, has normal vital signs, and on auscultation, systolic murmur was heard. She booked in a clinic kesihatan and was rightfully referred to the tertiary center for escalation of care. She was then seen in this tertiary center at 16 weeks by Dr. A, who laid out a routine care plan, which includes repeat echo, and the doctor thinks that the detailed scan is needed at 20 weeks, and a combined clinic appointment was set in that tertiary center. So this patient came to combined clinic at 20 weeks and was seen by Dr. B now. Her echo revealed moderate mitral regurgitation, dilated LA, and mildly depressed left ventricular function with the ejection fraction of 50%. The patient remains asymptomatic, and hence she was referred as an outpatient to the cardiac center for cardiac combined care. At 24 weeks, she was seen by a junior cardiologist in the cardiac combined clinic, who repeated an echo and noted it was a moderate to severe MR with dilated LA and an ejection fraction of 45 to 50%. The patient remains asymptomatic and very well, and hence she was planned for a TCA at 4 to 6 weeks with a repeat echo to see how she fares and what is her progress in pregnancy. So patient happily returned to tertiary center, and now she's seen by Dr. C at 26 weeks. She reported occasional dyspnea, but was taken as likely physiological in pregnancy. The plan from cardiac combined care was noted, and Dr. C decided that we can continue with the TCA date given by the cardiac combined clinic. A referral was made rightfully to anesthetist for pre-op assessment. Now at 29 weeks, she came in presenting to tertiary center with heart failure symptoms, and routinely we strapped the patient on CTG, and unfortunately the CTG shows features of acute fetal compromise. Decision was made for cesarean section. She went for cesarean section under general anesthesia. The baby was delivered, and patient developed arrhythmia on table. Resuscitation was initiated, but unfortunately the patient succumbed. Now, what went wrong? The patient was appropriately referred to tertiary center for escalation of care. She was seen by appropriate experts, which include the cardiologists and the obstetricians, but still she experienced poor maternal outcome. Is it because of lack of ownership of the patient? There was lack of leadership in the management of this case. There was lack of experience in the obstetricians managing cardiac patients, or lack of experience in the physicians managing obstetric patients. There was lack of synchronicity in management of care, and there was certainly dilemma while making a decision when there was maternal and fetal compromise coexisting at the same setting. Is there a role for MFM specialists here now? I believe yes, there is. And let's look at the proposed referral pathway instead. How can we make this better and change the outcome? Booking at primary healthcare institution at early pregnancy. The referral should be made to maternal fetal medicine specialists who will assess the patient in the maternal fetal medicine clinic. If the patient is deemed high risk and require urgent cardiologist input, the patient would immediately be referred to the cardiologist with cardio-obstetric experience, such as Dr. Aslanif, and an MDT can be arranged immediately to discuss urgent matters. And if patient is deemed suitable to continue pregnancy, this patient can be followed up closely in cardiac obstetric combined clinic, and an additional MDT can be done or can be arranged later to decide on to discuss about the progress of pregnancy and decide on management in later pregnancy. And if the patient is deemed moderate risk, she can then have her follow-up appointment in cardiac obstetric combined clinic, and an MDT be arranged later on in the pregnancy, especially to discuss about her delivery plan. So what is the advantage of this pathway? It shortens the waiting time. We identify high-risk cases, such as in this case, moderate to severe MR with depressed left ventricular function, and MDT can be arranged as soon as possible to design a holistic care plan after discussed with multidisciplinary team experts. Next, let's see what we do in the MFM clinic. The European Society of Cardiology proposed the initial assessment for all cardiac patients in pregnancy, including risk stratification, a detailed and thorough history taking, clinical examination, a baseline ECG, some baseline blood investigation, which includes hemoglobin, renal profile, coagulation profile, especially for patients with mechanical heart valve on warfarin. Pro-BNP, if this is available in your center, it should be done because we know a baseline pro-BNP of above 128 has got an increased risk of adverse maternal outcome. We as obstetrician need to know whether need to confirm whether this is an intrauterine pregnancy and establish the viability of this pregnancy. This patient can be subjected to 6-minute walk test if she is to establish her exertion tolerance. And this is mainly to measure their heart rate and saturation after exertion. A baseline echocardiogram should be arranged to identify the current status of her valves now. And perhaps a cardiac imaging is needed if it's indicated. Let's look at risk stratification. So, like what Dr. Aslanif has said, the ESC guideline actually recommend the classification, the modified WHO classification, and this classification mainly look into specific cardiac lesions and classified patients into MWHO class 1 to MWHO class 4, with class 1 being mildest and class 4 being most severe. And with this, they actually stratified the risk of maternal mortality and morbidity and the possibility of the occurrence of maternal cardiac event. This is a summary of the modified WHO classification, and we can see patients who fall into class 1 actually has insignificant increased risk of maternal morbidity or mortality and a very low risk of maternal cardiovascular event of about 2 to 5%. Whereas in patients with severe MS or symptomatic AS, there is a risk of almost 100% of developing cardiovascular event during pregnancy. And based on this, the care during pregnancy and visit during pregnancy can be catered accordingly. Now, modified WHO classification is good, but it's only specifically using cardiac-specific lesion. So what this group in Canada and in Netherlands propose is another screening tool which uses prior cardiac event and functionality of the patient to predict the maternal risk. And if we look deeper into Zahara and Kaprek, the criteria is almost the same, mainly on prior arrhythmia or prior cardiac event, their NYHA class and cyanosis, left heart obstruction, mechanical valve prosthesis, and all these will give a sum of points, and these points would direct us to the possibility of development of adverse cardiac outcome. If we look at here in the Zahara score, if the point is about 0.5, the risk is about 2.9%, and this is equivalent to modified WHO class 1. And if the point goes above 3.51, the risk is about 70%, and this is equivalent to modified WHO class 4. Recently in the Journal of American College of Cardiology as well, Pandey et al. Has proposed another screening model using the Devi score and the valvular heart disease specific tool. So this is specifically for patients with valvular heart disease. And using this score, they could identify patients at higher risk of adverse maternal outcome better than using the Kaprek score. Although this is not fully validated and is yet to be recommended, we should watch this space. All these risk scoring systems are good because it helps us to predict the risk of maternal morbidity and mortality and cardiac event. But it does not include comorbidities of the patient, the BMI of the patient, and social and economic factors of the patient. Let me give you an example. I have Madam J here, who's 42-year-old Nali Paris, non-chronic rheumatic heart disease with mild to moderate MR. She has had no prior cardiac event and is asymptomatic. So she falls into modified WHO class 2. When she comes to the MFM clinic, what we notice is she now actually has a twin pregnancy, which she conceived via IVF. Her BMI is 42, and she's actually a known case of SLE with interstitial lung disease. So it is the maternal medicine specialist's responsibility to tie up all these risk factors and create and design a holistic care plan to ensure a good pregnancy outcome for these patients. So it's not just merely the risk scoring system, but also everything that accompanies this patient. And let's look at a detailed history. What should be taken when you are, what consists of a good history taking? Symptoms, the current existing symptom of a patient to know the functionality of the patient, underlying comorbidities, latest cardiologist review whether this patient was recently just stint in a pre-pregnancy clinic or the patient has defaulted follow-up for 5 to 10 years ago. What is their latest investigation findings for us to identify the progress of their disease, the current medications, whether there is any need to switch all these medications into a more pregnancy-friendly medication. If she has had a past pregnancy, what was the outcome? We also need to look into their other habits such as smoking, substance misuse, or alcohol consumption. And in our country, I think economical background is also important because that would allow us to sort of gauge whether this patient will come back and will be compliant for follow-up or not. What about investigation? So the ESC proposed a baseline ECG, blood investigation, echocardiogram, exercise stress test, cardiac imaging, and occasionally, although extremely rarely, right heart catheterization, because this should ideally be done preconception. A patient who will do well in pregnancy is one who has a modified WHO class 2 or lower, a low Kaplan or Zahara score, someone who is asymptomatic with a low-risk lesion, someone with no progress noted on their echo, and someone who can tolerate exercise stress tests very well. And with the significant hemodynamic changes throughout pregnancy, do we expect the similar findings on ECG and echo in a pregnant patient compared to the non-pregnant patient? We know that there is significant evidence to support that there is normal changes normal ECG changes in pregnancy, and this includes increased heart rate, a Q wave in lead 3, a shortened PR interval, and leftward deviation of the QRX complex. Commonly seen changes include transient ST or T wave changes, Q wave and inverted T in lead 3, attenuated Q wave in lead AVF, and inverted T wave in chest lead V1 to 3. What about echocardiogram? Recently, the British Society of Echocardiography and the UK Maternal Cardiology Society has published a position statement on transthoracic echocardiographic assessment of the heart in pregnancy. We know that there is increased heart rate, cardiac output, stroke volume, and a significant reduce in peripheral vascular resistance in pregnancy. What should remain unchanged is the bilateral ventricular ejection fraction, means the systolic function, and the pulmonary arterial systolic pressure. It is very common to see small pericardial effusion in pregnancy. Aortic root and ascending aorta should remain unchanged, and a rapid increase of nearly 5 mm should prompt discussion for therapeutic option. There can be increase in the left atrial diameter up to about 13.6% from baseline. There can be an increase of left ventricle end-diastolic diameter up to about 4.6%, and there is an increase in left ventricular mass, especially in patients with hypertension in pregnancy. In a nutshell, there is an increase in left ventricular dimension resulting in eccentric symmetric hypertrophy. There is about 5 to 10% overall increase in left ventricular mass and wall thickness of about 25 to 30% above pre-pregnancy level, and these are all considered normal. There can also be hypertrabeculation in pregnancy. And due to the chamber dilatation, the tricuspid, mitral, and pulmonary annulus actually increase in size, and therefore it's common to see mild mitral, tricuspid, and pulmonary regurgitation in pregnancy, and all these can be considered normal in pregnancy. Given that echocardiogram is such an important tool in assessing valvular heart disease in pregnancy, we need to know the difference between transthoracic and transesophageal echocardiogram, as per discussed by Dr. Aslanif. Transthoracic echocardiogram is easily accessible, is safe in pregnancy, well tolerated, and does not require any sedation. The downside of it is patient may have difficulty lying in supine position, especially in third trimester. And in supine position, there is reduce of preload secondary to aortal cable compression, and this may reduce the accuracy of echocardiogram. Ideally, these patients should be positioned in left or right lateral. Our pregnant ladies are larger structurally. They have narrower intercostal space for acoustic window. They have increased movement of their thorax due to hyperventilation, and the breasts are larger, limiting the space for performing echocardiogram. What about transesophageal echocardiogram? It's superior in the terms that it offers clearer images with improved diagnosis and prognostication. It will be needed when intervention is indicated. Unfortunately, patient will need to be sedated. Most of it is done under general anesthesia with intubation, and as such, there is higher risk of aspiration. What about exercise stress test? Is it safe in pregnancy? The ESC guidelines suggest sub-maximal exercise tolerance, meaning patient only have to achieve less than 80% of predicted maximal heart rate in asymptomatic pregnant patient with suspected heart disease. Stress echocardiography using bicycle ergometry may improve diagnostic specificity, and cycling is preferred to treadmill because it improves stability and hence reduces the risk of fall and eliminates influence of the gravid uterus and gestational weight gain. Dobutamine stress test is rarely indicated during pregnancy. Let's look at cardiac imaging. We know that echocardiogram is the basic tool when it comes to cardiac imaging, it's important to evaluate valve stenosis, valve regurgitation, proximal iontopathy, and ventricular function. It's easily available, non-ionizing radiation with no gadolinium involvement, but there is limited visualization of thoracic aorta. What about MRI? MRI offers excellent resolution with no ionizing radiation. It offers complete visualization of the aorta. It helps to assess ventricular function and specific cardiomyopathies, aortopathy, and valve dysfunction. Unfortunately, patient has to stay a relatively long time in the scan machine, and sometimes there may be limitation in terms of patient having to fit in the MRI machine in third trimester. The image quality may also be adversely affected by arrhythmia. Contrast-enhanced CT is rarely indicated due to the radiation, but it can be considered if it's really indicated. When it comes to radiation, what everyone is concerned is obviously the fetal radiation dose. We know the threshold dose is less than 15 milligram, and this paper was published recently looking at the potential fetal effect of radiation exposure and excess risk of cancer by fetal radiation. And if you look into it, dose of 10 milligram only incurs a very low increased risk of cancer to the unborn. And we know that most of our cardiac imaging actually only subject the patient and the fetus to less than 1 milligram. Hence, cardiac imaging is actually safe in pregnancy. Now let's talk about MDT. Everyone thinks that the maternal fetal medicine specialist loves MDT. Why so? It is important that we discuss about management of patients with complicated medical condition, such as one with valvular heart disease in pregnancy. It is done in the presence of all relevant expertise, where you have the whole cardiac obstetric team, the cardiac surgeons, the anesthetists, the nurses, and all. And we are able to discuss together about things such as suitability to continue or to conceive pregnancy, our management plan, be it pre-pregnancy plan, antenatal, intrapartum, or postpartum care. All this discussion is important so that all of us are in the same page when it comes to management of this individual patient, and it can be done more than once for any given patient. So let's look into the management of patient with valvular heart disease. So Prof. Uri Al-Khayyam actually came up with a guideline and an illustration here, which showed which proposed the algorithm and the management for patients with a valvular heart disease. So preconception assessment is important. Shared decision making with patient is important, but the decision to proceed with pregnancy, follow up during pregnancy, pre-delivery, and delivery and postpartum care are all accurately and detailedly written in here. Our Ministry of Health also published a clinical practice guideline in 2016 with regards to heart disease in pregnancy. And we do have our own algorithm as well. And here we classified patients according to modified WHO class, and those with low risk can be seen in primary care. And the number of visits is depicted here. And these patients would certainly also need to be referred to tertiary care at least once or twice to be seen by the obstetrician and the cardiologist. And when it comes to patients with higher risk, they should only be managed in tertiary center by the MFM specialist and obstetrician consultant and the cardiologist and MDT team. During the MDT, we also discussed about delivery, the delivery care plan. Timing of delivery usually aim at full term, and obviously spontaneous labor is preferred. For patients with severe lesion, those with modified WHO class 3 and 4, we may consider planned delivery, and they should be delivered in a specialized center with multidisciplinary team, especially the cardiologist on standby. Mode of anesthesia needs to be discussed as well. Patients are recommended for epidural if they are going through vaginal delivery, and that is important to avoid hypotension during regional anesthesia. And a patient going through cesarean section can go for a CSE as well. Vaginal delivery is most appropriate, and most of our patients have no contraindication for vaginal delivery unless patients with severe symptomatic aortic stenosis or mitral stenosis, patients with acute decompensated heart failure, or patient who has recently taken warfarin within the last 2 weeks. We may consider assisting the second stage by using forceps or vacuum, and that is to reduce the duration of Valsalva maneuver for patients with moderate to severe stenotic lesion. Although we do recommend assisting second stage, but this remains quite gray. Reason being, we are not sure shortened second stage means do we allow 5 minutes, 10 minutes, or 30 minutes duration for the patient to push, or should we just proceed for instrumental delivery the moment the patient is fully dilated? Also need to bear in mind that there is always risk of complications to the mother and the fetus when we perform an instrumental delivery. Postpartum, we need to anticipate volume overload, especially in patients with moderate to severe valve lesion. Consider monitoring patients of high risk in ICU, and the patient should be hospitalized for monitoring for more than 72 hours after delivery, because we know that the cardiovascular adaptive changes its highest immediately postpartum up till 72 hours after. More importantly, do not forget a contingency plan, just in case if your patient comes in any emergency in delivery out of your plan. And the ESC guideline proposed the use of a pregnancy care plan, and this should be filled up and attached to patient handheld notes. And there are many international society which propose their own management and algorithm for management of patients with heart disease. This is one for congenital heart disease, but obviously it can also be employed for patients with valvular heart disease. And if you can see, patients are classified according to the WHO class, and care should be started from preconception itself, and it involves antenatal care, multidisciplinary team, and how we should monitor the patient during pregnancy, include fetal echocardiogram and maternal echocardiogram, and to consider serial BNP and anti-pro-BNP monitoring. Now let's swiftly move to controversies in management of valvular heart disease. This is a bit more interesting because it's newer. So in situations such as severe aortic stenosis, severe mitral stenosis, or mechanical valve thrombosis, or when you have deterioration of the valve condition, do we always have to deliver the patient? Maybe not. So this group, Frecaro et al., has published a paper on the interventional cardiology research, review research and resources, looking into management of valvular disease during pregnancy, specifically the evolving role of percutaneous treatment. And they propose for patients with severe aortic stenosis, balloon aortic valvuloplasty is safe in pregnancy and is mostly done. And if that fails, we may consider transcatheter aortic valvular replacement, although the evidence remains limited in this field. For patients with severe mitral stenosis, percutaneous mitral commissurotomy is recommended, and there is abundance of evidence on that. And if that failed, percutaneous mitral valve repair is now being studied, although it's mainly on animal model. We should watch that space as well. For prosthetic valve dysfunction, if we encounter mechanical valve thrombosis, thrombolysis is extremely important. There is study being conducted for transcatheter low-dose tissue plasminogen activator infusion as well. And for bioprosthetic dysfunction, a transcatheter valve implantation specifically for aortic is can be undertaken. And if all fails, surgical repair of valve can be done. Obviously, there is a significantly higher maternal and fetal risk for this, and its maternal risk is up to 2 to 10%, and there is up to 40% risk of fetal loss as well. Hence, this has to be discussed with multidisciplinary team and also with the patient herself. What about anticoagulation for mechanical heart valve? There are multiple papers being published discussing anticoagulation for patients with mechanical heart valves. And all these papers eventually would summarize to warfarin leads to fewest maternal thromboembolic and complications, but also with the least live birth. Safety of warfarin less than 3 milligram remains unclear. Sequential treatment, meaning you change from warfarin in early trimester to heparin or low molecular weight in second and third trimester, and then change it back to warfarin in second and third trimester, and subsequently back to low molecular weight heparin during pregnancy. This sequential treatment may subject women to higher risk of complication and certainly does not eliminate risk of fetopathy entirely, because we know that usage of warfarin in second, third trimester, although the risk of embryopathy is low, but there is increased risk of intracranial bleeding, which can lead to poor pregnancy outcome as well. Continuous unfractionated heparin may be more cumbersome and lack safety data. Low molecular weight heparin seems promising with anti-10A level monitoring, aiming for trough level at 0.6 to 0.7 and peak level of 1 to 1.2 in low-risk cases, and the peak level can be up to 1.4 in high-risk cases. There are papers such as the British Society of Hematologists proposed addition of low-dose aspirin in addition to the anticoagulation therapy. Delivery plan. This has to be done with multidisciplinary team, and an individualized care plan needs to be in place. Warfarin should be switched to heparin at least 2 weeks prior to delivery. If presenting in labor, patient on warfarin within the last 2 weeks should be subjected to cesarean section. This is to reduce the risk of intracranial bleed to the baby. Therapeutic low molecular weight heparin should be stopped at least 24 hours prior to surgery to facilitate neuraxial anesthesia. Prolonged pre-delivery interruption of anticoagulation should be avoided, such as in induction of labor. Therefore, we would recommend to consider using prophylactic or intermediate dose of low molecular weight heparin during this time. Prophylactic or intermediate low molecular weight heparin should be started within first 24 to 48 hours postpartum, and we may switch back to warfarin around day 5 to 7. This is according to the ESC guideline. But local experience, I would say we do encounter many intra-abdominal bleeding. Hence, perhaps after 2 weeks would be a wise choice. Surgical management is preferred for first trimester miscarriage. And as I've mentioned earlier, percutaneous balloon mitral valvulotomy has got abundant of evidence, and there has been over 700 successful procedures with the risk of complications, mainly mitral regurgitation. Those unsuccessful ones are mainly with the high Wilkins score, and there was 11 maternal deaths with a Wilkins score above 8. Who are those who qualified for this? Patients with severe refractory symptoms not responding well to medical management. But this patient has to have no significant mitral regurgitation. Percutaneous balloon mitral valvuloplasty results in substantial decrease in valve gradient and increased valve area, hence better outcome for the mother. And when we compare to open commissurotomy, the success rate is similar, but open commissurotomy poses 8 times higher risk of fetal loss. Lastly, I would like to briefly talk about pre-pregnancy care. Now, similar to antenatal care in maternal fetal medicine clinic, we would see this patient, re-stratify them, take a thorough history, perform a thorough clinical examination, have all the investigations performed, and re-stratify them. More importantly here is before pregnancy, we can subject patients to cardiopulmonary exercise stress tests because they are not pregnant yet. And if needed, a right heart catheterization should be done to estimate the patient's pulmonary pressure to exclude pulmonary hypertension in such a patient, because we know patients with pulmonary hypertension with valvular heart disease they do poorly in pregnancy. And after so, we would refer them to the cardiologist, and expert cardiologist review is needed. And those who fulfill guideline-based criteria for valve intervention should be counseled for intervention pre-pregnancy. And those who do well are those with low modified WHO classification, low Capret and Zahara score, asymptomatic with low risk lesion, those with a stable echo, and those who can tolerate exercise stress as well. Preconception exercise stress tests can include treadmill stress tests, cardiopulmonary exercise tests, and exercise stress echo as well, which all these are seldom done in pregnant lady. It's ideally to be done pre-pregnancy because it's easier for them to perform, and it's better for us to know their baseline before they embark on pregnancy. So after all the assessment, we would decide whether this patient is suitable for pregnancy, or does she need some time to optimize her condition, or we would say pregnancy may not be recommended. And The American College of Cardiology and American Heart Association also came up with a guideline for management of patients with valvular heart disease, and this is their pre-pregnancy care algorithm. So for those who we do not recommend for pregnancy, certainly contraception is important. Progestogen-based contraception is safe in pregnancy. Caution in use with combined hormonal contraceptive in patients with atrial fibrillation and mechanical heart valve. So lastly, I would like to summarize my talk with take-home message. MFM specialists plays a crucial role in the management of valvular heart disease in pregnancy. A good clinical history, examination, and baseline investigations is equally important to ensure good pregnancy outcome. MDT is an important element in the management of patients with complicated medical condition. Exercise stress tests can be performed safely in pregnancy, especially this bicycle ergometry. Transesophageal echo is safe in pregnancy. Cardiac image can be performed and is safe. Percutaneous valvular intervention is promising and safer compared to surgical intervention. And low molecular weight heparin is a promising option for patients with mechanical heart valve in pregnancy. With that, I would like to bring you the last key message as per promoted by the Embrace. Treat pregnant, recently pregnant, and breastfeeding women as a non-pregnant person unless there is a very clear reason not to do so.